You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Dr. Grandizio, welcome to the Nailed It Ortho Podcast. We are happy to have you on. Happy to finally meet up with you and talk some distal humerus. So, welcome to the podcast.
Thank you. I really appreciate the invitation. I had a chance to go through a number of your podcasts, and it's impressive amount of them, and very educational. So you guys should be proud of what you've been able to build.
Oh, very nice words. Thank you for listening. And we typically start out the podcast. A couple of questions, just getting to know you a little bit better. So, first question is kind of the age-old question, and we're talking somewhat briefly about this off air. But what made you choose hand as a specialty? I know you were saying you had other thoughts when you first came into residency, but then you ended up choosing to kind of hand and upper extremity. So what brought you towards that field?
So I had, I think, the really common orthopedic experience where, I played baseball in college and was pretty convinced that I wanted to do sports. And within my residency program, I was fortunate to have a lot of mentors in hand and upper extremity, and really found myself kind of drawn to those cases, particularly elbow. And so when I was looking at opportunities for fellowship, it was one of the ideas was what would be the best way to be able to do upper extremity from shoulder to fingertips, and with a focus in elbow. And I ended up doing a hand and upper extremity fellowship that sort of had an emphasis on the whole limb. So I had some shoulder and elbow, as well as hand and wrist.
Cool. Awesome. Yeah, I know a lot of people come into residency with we're going to do this because they had some, type of injury of sports, and, they think about sports, but I'm glad you kept your options open and ended up choosing hand, because we'll talk some good distal humerus things today. But second question I have for you is, do you have any interests outside of the field of orthopedics or anything that you like to do?
So I joked for a lot of years, I think with residency and fellowship, that I have no hobbies, and I was really in need of a hobby. But I have two young sons that are 6 and 4.
Nice.
They are just old enough to start playing like soccer and t-ball. So my new hobby, my new interest is now coaching.
Nice.
Which is really exciting, and is a nice change of pace from work.
That's pretty cool. And then the last thing I have for you is, do you have a favorite case, like a favorite operative case that you like to do? You see it on the board, you're like, I'd say it's going to be a good day.
Oh, that changes every day. I think at some point yesterday, I declared that arthroscopic lower trapezius tendon transfers were my favorite case. I think at one point during my OR today, elbow capsular releases, distal humerus fractures are up there. But if I really had to choose, traumatic elbow instability is probably my favorite case, unless it's a particularly bad day, and then it might change. But I think one of the interesting aspects of doing elbow surgery is that there's such variety. Everything from trauma to arthroplasty, nerve and soft tissue cases, and so I think it's tough sometimes, I think, to pick one thing. But if I had to, traumatic elbow instability.
Yeah, there's always a lot of cool things about the elbow and different cases, especially those instability cases where you fix one thing and the elbow's still unstable, and then you kind of trying to figure it out. And once you finally get it, it's a nice feeling. But moving forth to what we'll talk about today, we're going to talk about distal humerus fractures. And let's just say, just random case, we have this, 45-year-old guy in a high energy motor vehicle collision, and, the ED call says that they have, this patient that has this distal humerus fracture, and he's nerve-vascularly intact, and that's all that they tell you. I guess kind of back, going a little bit back forth, what are the most, when we're talking kind of just about like mechanisms of injury, what are the kind of common mechanisms of injury or things that you normally know with a history whenever you have a patient, either young or old, that has a distal humerus fracture?
So there's a little bit of a bimodal distribution. We see a lot of high energy younger patients, either motor vehicle collisions, fall from height, type of mechanism, and then there's the second peak and sort of elderly, perhaps lower demand fragility fractures, and those can come with underlying medical conditions and falls, gait instability, sarcopenia, and so it's a little bit of a mix: the elderly lower demand fracture, low energy fracture, and then younger patients with high energy trauma, often with multiple injuries.
Yeah, and then say for example you have you have a resident that's telling you, or they went to see the patient and they're telling you about this fracture, or about this patient that has this fracture. What are some of the important things that you want to make sure you hone in on when you're talking kind of about a physical exam and examining these patients?
So I think the component, especially in the workup in the emergency department, is rule out associated injuries, and in that extremity or in the in the lower extremity as well. Compartment syndrome is not as common in a distal humerus fracture as it is in some of the lower extremity fractures. That's certainly always important to look for. I think it's important to assess the quality of the skin and soft tissues. Subtle poke hole or grade 1 open fractures are important to look for on exam. And then, I think a detailed neurovascular exam is important. There's certainly associated ulnar nerve injuries, radial nerve injuries, and I think those are important to know the status of before you potentially take that case to the operating room. And so those are I think the key points that I'll ask our residents to look at when they evaluate the patient in the emergency department.
Yeah, I always think that's super important, especially if you take them back to the OR. And I know sometimes with a lot of these procedures, one of the first things a lot of people may do is dissect out the ulnar nerve, and just so like where it is, and then you can kind of go about your case. But if you don't have any like really good documentation beforehand, knowing the function, and then afterwards they have some type of decreased sensation, it's kind of it'd be nice to know what exactly how it was before, so you can know if anything changes after the OR. So just kind of reiterating that, definitely doing a good physical exam, neurovascular exam with these patients is very important, and looking for any open wounds. When it comes to imaging, what images do you want for this patient? Do you just get elbow? Do you get humerus, shoulder, down the wrist, or what is your typical protocol?
So in a patient with an isolated injury and doesn't have wrist pain, I do think it's important to get joint above and joint below. So images that will show the entire humerus, orthogonal radiographs of the elbow. So an AP and an AP and lateral radiograph of the elbow. I think in a lot of cases, particularly in the ER, traction views can be particularly helpful for preoperative planning. And I think more commonly, CAT scan with 3D recons can change the management and help better understand the fracture.
Yeah, and I forgot about the traction view, but yeah. So do you typically do that when you have like a really displaced comminuted intra-articular distal humerus fracture? And when you get the traction view, are you just trying to see how it generally aligns, or just get a better view of the fracture itself? Like, what is your goal with the traction view?
I don't get it in every fracture. I do think that for younger patients with comminuted, particularly intra-articular fractures, that view can be helpful. And sometimes in older patients as well, particularly when you're trying to decide between perhaps fixation and arthroplasty, you can get a lot of information from the 3D recons, but the traction views can be helpful as well. It's one of those things that I've never regretted getting one. It's an additional piece of information, but I don't get a traction view on all cases, particularly for extra-articular fractures.
Yeah, and so I assume for this the CTs where you're getting the 3D reconstructed image, is that mostly just for your just really comminuted like articular fractures of the distal humerus, or are you getting it like for your trans like your trans columnar fractures as well?
So I think in my practice, in particularly if they're referred in an outpatient setting, they often come in already having had a CAT scan with 3D recons. I think there's no question that it can, in some cases change management, and particularly in really low transverse bicolumnar fractures, when there's any concern for a shear component of either the capitellum or the trochlea, they can be really helpful, and I think can change approach, procedure, and management.
Okay, and then when it goes to classifying these distal humerus fractures, are there any classification systems that you use or that that are used at all, Ben?
So I think the AO of generally classifying them as A, B, and C type fractures can be helpful. I mean, knowing if it's an extra-articular bicolumnar fracture or a comminuted, C3 intra-articular fracture, they're helpful for research. But I think more practically, the descriptive classification system is helpful. Bicolumnar, intra-articular, extra-articular. I think another component of that is, there's the Brian Morey, and it's been modified a few times for shear fractures of the capitellum and trochlea. And I think that classification system can be helpful to understand what you're dealing with, and in some cases can guide treatment. But I think generally, at least the way that I discuss these, are often a descriptive classification in terms of describing the fracture location and the fracture components.
Yeah, I had to add that Brian Morey, that classification system to the notes. I remember reading it one time, and not quickly forgetting it, but just I remember reading it and saying I need to go back and look at this.
It's hard because each of them have like an eponymous term associated with them, but it classifies the location and sort of how comminuted the capitellar shear component of it is.
Okay. And so can we kind of touch base on, I think we did a good job kind of just going over just this, quick, high points of what to look for in H&P and imaging. Can we touch quickly on the plain old anatomy? We're kind of just taking it back to basics. Say, sometimes we have interns and junior residents that are listening on here. Sometimes we have medical students on here as well. But kind of just the basics of the anatomy of kind of the distal humerus, the important things to know. And typically, we can go through some of the bony anatomy and then go through some of the soft tissue things and just kind of the high pertinent things we should know about distal humerus.
Sure. I think elbow anatomy is fascinating, and I think it's an area that there's sometimes some apprehension about operating, particularly with complex cases or bigger exposures. You have neurovascular structures all over, very close to your incisions and to your operative exposures. And so I think when we're talking about the bony anatomy, the key is the ulnohumeral joint, and it can function essentially like a hinge. And so everything that you think about, whether it's traumatic elbow instability or distal humerus fractures, is sort of restoring the hinge and restoring your ulnohumeral joint. It's highly congruous, which is one of the challenges with getting an anatomic reduction and some of the issues with post-traumatic arthritis. But I think I like to think of the trochlea as a spool. And one of the things I've found helpful, I think, especially in the age of 3D printing, when you're doing starting out with some of these complex distal humerus fractures or shear fractures, it's really helpful to keep like a sawbones or a 3D printed model, of the distal humerus, like a sterile bag on the field, just to kind of refer back to. I think that can be helpful. But I think the image you have up with the columns, the medial lateral column and the tie arch, is something that a conversation that we get into with plating constructs and restoring that Roman arch kind of configuration. But it's complex osseous and soft tissue anatomy. I think that's what makes it a very interesting part of the body to operate on.
Yeah, and I just recall, I think I was reading something and it was saying that that if like there's anything that you want, I think it was saying like one of the superior pieces of the trochlea, like you want to, if there's anything that you want to align, you definitely want to try to get the trochlea aligned. Well, of course, with the proximal ulna, just to, again, just kind of reiterating that point of making sure that your ulnar-humeral joint is intact. Like, have you read that, or am I making this up?
No, not at all. I mean, the restoring the anatomy of the ulnar-humeral joint, I think, is a critical part of any operation, whether you're talking about a distal humerus fracture or traumatic elbow instability. The radiocapitellar articulation, I think, can there's a little bit more tolerance on the lateral side. But you're absolutely right. The central spool and superior aspect of trochlea, I mean, that's all important areas to restore.
Yeah, and what are some of the things that we, anatomy wise, that we need to know about the soft tissues when we're talking about the elbow and then these different fractures and fixing them, that we just need to consider?
I think keeping in mind where your ligament origins, both on the lateral and the medial side, I think that understanding how to make your approaches extensile in terms of how to find the radial nerve proximally or laterally are important. But I think as you get into more complex exposures, I think knowing where your lateral and collateral ligament and particularly your anterior bandy or medial collateral ligament, I think recognizing where those origins and insertions are important.
Okay, and then you mentioned you briefly just mentioned finding kind of your radial nerve. What are some, I guess, just important nerve things to know about the elbow, as far as distance wise, or any tips or tricks or anything that as far as being able to kind of visualize and figure out exactly what some of this nerve and vascular anatomy is?
Sure. So I think each of these, particularly for hand surgeons, could fill an hour, because we love finding nerves. But the ulnar nerve, I think in a lot of the traumatic cases, I tend to try to find this proximally to the medial epicondyle, retract the triceps, put some tension on the triceps, find it proximally outside of the fracture field, and then work distally, Osborne's ligament, and then in between the two heads of your flexor carpi ulnaris. I think that's the most familiar nerve to find and expose. The radial nerve, for most distal humerus fractures, outside of your kind of spiral distal third shaft, I won't routinely find it. But again, if you find that you need proximal extension, it's very important to know how to get there. Often you can trace the sensory nerve back from the fascia laterally into the main trunk. I think that number that you have up there, the 14 centimeters proximal to the lateral epicondyle, I mark that out in all cases, preoperatively, so that I know. I think another way of finding it is if you look at the triceps fascia, about a finger's breadth above the end of the triceps tendon fascia proximally. If you dissect straight to bone there, the radial nerve is usually crossing the posterior aspect of the distal humerus. And so I think it's something I try to emphasize with our residents, that it's important to know a few different ways to find it, and how to find it proximally, how to find it distally. I think it takes away a lot of the apprehension that people have about having to extend your exposure or having to get a more extensile view if you can find those nerves. I think the median nerve is a little bit less common to have to find in the distal humerus fractures, particularly from a posterior approach. But again, running with the brachial artery, important to find in both medial and anterior approaches to the elbow.
Yeah, and then I always see some things about like the blood supply to the elbow, and I know it's tenuous, and there are a lot of different vessels. Is anything that you think that we should know about necessarily the blood supply?
I think particularly in the pediatric population, the blood supply coming in posterior to the capitellum is important, and it is something to preserve. I think that's an important aspect, particularly for peds patients.
Yeah. Okay. So I guess we can kind of move forward to treatment and in these patients. Now, are there any patients that have any distal humerus fractures that you're treating non-operatively? I've written books, and a lot of them say different things, but in your practice or anything as far as non-operative treatment, are there any indications for that? And then what is the treatment that you would employ if you are going non-operative?
So I think this is a really interesting aspect of distal humerus fracture care. If you look at trends for particularly in elderly patients with isolated upper extremity fractures, I think there's been a big shift in the trend towards treatment towards non-operative treatment. So we know a lot of proximal humerus fractures, a lot of humerus shaft fractures can be managed non-operatively. I think one of the biggest changes to my practice when I first started was managing displaced olecranon fractures in patients over 75. I can't remember the last time I've fixed one. And the results, I think anecdotally and what you see in randomized series have been pretty good. And the same for distal radius. There's a lot of evidence for close treatment of isolated distal radius fractures. But isolated distal humerus fractures, we don't talk about non-operative treatment as often. And if you look at some of the retrospective historical series, they have a high rate of non-union, as high as 50% in some cases. The functional outcomes are not great. And I think part of that is due to there's a 40 to 50% 5-year mortality rate. So I think we're electing to treat very sick elderly patients non-operatively, but I wonder if this will be an area in the future that may follow some of the trends of other isolated upper extremity fractures in this population. I think that to answer your question, right now my indications for non-operative treatment are non-displaced or minimally displaced fractures, particularly in older patients. Or displaced distal humerus fractures in patients that wouldn't tolerate an operative procedure. I think there's a lot of variability in terms of how people manage that fracture non-operatively. I tend to go with a short period of cast or splint immobilization. And then allow them to start some range of motion within a range of comfort around that 3 or 4 week mark. But I think that there's a lot of variability in terms of how people treat these fractures non-operatively.
Yeah, and is that kind of that bag of bag of bones? Like if you have like an old patient that has like a severely comminuted distal humerus fracture, that what? I feel like I've heard that you're treating those non-operatively.
Yep, it was a highly comminuted fracture that we may consider a total elbow for in a patient in their 80s and cast. And I will say that the majority of these that I've treated non-operatively have been in patients with long-standing rheumatoid disease, and they seem to tolerate it quite well. And that may be because they have some underlying dysfunction in the elbow, to begin with. But yeah, I think that it's often referred to as the bag of bones treatment, whether that's, some people do cast, some people do cuff and collar. Like I said, I tend to do a brief period of immobilization around 3 weeks and then let them start range of motion.
Okay. And so, that's kind of our non-operative treatment. So what patients, I guess, is operative treatment going to be indicated for?
So I think the majority of young patients with displaced fractures, we consider operative treatment for. The same thing for lower energy, older patients, displaced fractures, intra-articular fractures, bicolumnar fractures. I think those are the patients that we're more commonly discussing operative treatment for.
Yeah, and so one, I've seen different things regarding kind of the timing of treatment. Some places were saying, if you ideally you treat these, earlier you can, like within 48 to 72 hours. Others are saying, you can at least within 2 to 3 weeks. Any thoughts as far as timing for treating these distal humerus fractures?
I think this is an area of active research, and this conversation comes up particularly in the total elbow when discussing total elbow for distal humerus fractures. Is there a benefit to letting the soft tissues cool down, so to speak, for a week to 2 weeks to 3 weeks, or is there a risk of HO, with waiting? And so I think it's a little controversial, and I think a lot of it depends on practice and how these patients are referred in. If a lot of these are coming in through your ER, and you're able to fix them acutely, versus patients that are referred as an outpatient, and you're seeing them maybe 3 or 4 days after injury, and then operating on them the following week. But there's the idea that theoretically earlier surgery within 72 hours may lead to decreased heterotopic ossification and stiffness, and the sort of theoretical advantage of waiting, is perhaps the skin and soft tissue envelope is less inflamed. But again, I think a lot of that is surgeon preference and practice structure, sort of in the absence of definitive evidence.
Yeah, and speaking about like skin and soft tissue injuries in patients that have open fractures, does your algorithm change at all? Do you ever use an X-fix? If you have a really comminuted, distal humerus fracture with, a lot of soft tissue loss, or does your treatment algorithm change at all for any open fractures?
So for me, it doesn't. If I'm on call and there's an open distal humerus fracture that's not contaminated, would plan to take that to the operating room for irrigation debridement, and would fix it in in the same setting, in the absence of contamination. I think that I work in kind of an integrated system with a lot of community affiliated hospitals, and in some cases, if there's an open distal humerus fracture, you may wash it out, and splint it, and then their definitive surgery is later for ORAF. I don't think there's a big role for X-fix of these distal humerus fractures for open fractures for temporary stabilization. I think that if you're on call and not planning to treat a distal humerus fracture definitively, I think that it's reasonable to perform a debridement and irrigation, and then a splint. In my practice, I reserve external fixation for distal humerus with vascular injury, where they can't have ORAF, or that they're getting a vascular procedure, but it's pretty rare, I think, for external fixation for distal humerus fracture.
Okay. And all right, so say we have this patient, bad distal humerus fracture, comes in, you're planning on fixing it. How do you position? Do you position prone, or you have them supine? What's your kind of choice?
So for your standard bicolumn distal humerus fracture, planning an ORAF, I position those lateral. I will use like a bone foam, or if that's missing, just pillows to lay the arm across. So lateral beanbag with a radiolucent table. And I think it's important particularly when you first start, to make sure you bring X-ray in and get images before you prep and drape. There's nothing worse than having the patient positioned and then finding out that you can't move your X-ray machine the way you want to be able to get the images that you need to get intraoperatively. And sometimes you can get overlap from the well arm if it's not positioned appropriately. If you're on the wrong table, you have you can have the metal bar in your field. Sometimes the patient isn't rolled over enough if they're lateral. So I think when you first start doing these, it's absolutely worth getting an AP and lateral radiograph before you're prepped and draped to make sure you're positioned appropriately. I have partners that position them prone, so I think they're all it's all an option. But my preference is to position these lateral.
Okay. Yeah, we have attendees that do similar things, but all do different things. One that does lateral, kind of the same positioning that you said, and another one that does all of his distal humerus is prone. So I guess kind of all dealer's choice when it comes to this.
For like a shear fracture, capsular shear injury, where I'm going to do a lateral column or lateral approach, I'll most commonly position supine. But I think there's, within lateral positioning, there's a lot of variations. And I think it's important to just have a reliable, reproducible way that lets you easily get X-rays. And I think that's the important part, is that, you're not struggling to get the films that you want.
Yeah, no, I completely agree. And a tidbit again for all those listening, definitely get those shots beforehand. Make sure you can actually see what you plan on seeing, and don't make the nurse, go in there and under the drapes and try to move stuff 30 minutes into the case, because that never goes well.
Nobody's happy when somebody's diving under the drapes to fix a problem.
Nobody's happy. And so moving on, we have this positioned and we're ready to do the case. Can you kind of walk us through some of these distal these different approaches for the distal humerus? I know there's a bunch, but can we kind of go through some of these, and how do you choose what approach that you're going to do as well?
I think this is another area that's can fill an hour. There's so much variation in terms of how people approach these. And I think that a lot of times people look for an algorithm in terms of this fracture, I do this. And I think there's a lot that goes into it. I think generally speaking, we're talking about sort of three categories. So a triceps on approach, where you're doing your paratricipital or other variations, and you're leaving the triceps on its insertion on the olecranon. There's a triceps off, and there's a variety of ways to do that. And triceps split. I use a triceps tongue, or what's referred to as a modified Van Gordner approach, quite frequently. And then, there's olecranon osteotomy, which is among the more extensile approaches. And so in general, for distal humerus fractures, an extra-articular fracture is a case that I'll routinely do with the triceps on paratricipital approach. I think that for fractures with a simple intra-articular component, or when there's not comminution of the central region of the trochlea, I think you can still manage those with the triceps on in a paratricipital approach. And the really nice thing about that approach is that you can do your paratricipital approach, you can extend distally, and you can do everything you need to do up to the point of doing an olecranon osteotomy and try to reduce your fracture and try to do what you need to do. And if you can't, you've done most of the work already. And then, you can extend that into an olecranon osteotomy. So for the majority of younger patients, where, an arthroplasty is not a consideration, I start with a paratricipital approach. And if I can't see what I need to see, and I can't reduce the fracture adequately, then I'll extend and do an olecranon osteotomy. I tend to take the triceps off, or do a triceps tongue type approach, which is sort of a modification of a VY in in patients where there may be a consideration of a total elbow. So that sort of elderly patient with an intra-articular fracture, that's an exposure I'll use, use frequently. There's a lot of variation, within each of these. I think it's important to kind of understand the advantages, disadvantages of each of them. Certainly the olecranon osteotomy is your most extensile. There is some concern, however, about, if you have to convert or you have to do an arthroplasty, with that type of an approach.
Yeah. So just going back to it. So say, we have our different approaches. This is all kind of just going from like, you're doing your posterior skin incision, you have your subcutaneous flap. So you said one is where you can actually just split the triceps. So you make an, incision right along through the fascia, through the tendon, you split it to gain access to kind of that posterior humerus. The other is where you make paratricipital windows. And so do you go down and do you dissect out your ulnar nerve first, or how do you typically do this? Do you go down and dissect that out, or what do you do?
Yep. So for all of these cases, it's a posterior skin incision. And the first thing I do is find and dissect the ulnar nerve. So I'll typically find it proximally, dissect distally, decompress it at Osborne's, and then decompress in between two heads of the FCU. I think there's some controversy about transposition, but I think exposure of the ulnar nerve is the first step of that case. And I think from there, you then decide which approach you're going to use: triceps on, triceps off, or an olecranon osteotomy. And within each of those categories, there's certain variations. I think most commonly do a posterior paratricipital, where you're making medial and lateral windows and leaving the triceps on its insertion.
Yeah, and so you're just lifting the triceps off the lateral and medial intermuscular septum when you're doing that. Do you just use a cob, or do you make an incision?
So I'll make an incision and then use a cob to dissect, and then you can use either an Army Navy or sometimes a blunt Hohmann retractor to move your triceps. I think the disadvantage of that is visualization in the central trochlea. And so for anything other than a simple articular split, or certainly if there's trochlear comminution, you do not have enough visualization, and you need to do something. Most commonly, need to do something more extensile.
And it's kind of, can you walk us through this like Anconius peel and slash the triceps reflecting? How do you typically do that? You just kind of lift it all off as one big big sleeve, or do you do this? How do you do that?
So this isn't an exposure that I use very frequently for distal humerus fractures. The advantage here is that you're reflecting the triceps off and maintaining, through the Anconius pedal and through the Anconius blood supply. And so it allows you for a little bit better view of the distal humerus without doing an olecranon osteotomy. Okay.
And then so what, because I've always read different things as far as, not I haven't read different things, but I've always see the osteotomy shape mentioned, or kind of how you do it. Can you kind of touch on our chevron versus our transverse osteotomy, if there's any difference between the two?
Sure. And I think when you're doing an olecranon osteotomy, I think that the steps leading up to it, are really important. And again, if you're doing your paratricipital approach and you extend your soft tissue planes distally, you're able to visualize it. You want to make your osteotomy in the bare area between the two facets, the olecranon. So I will typically take a K-wire at the apex of that chevron, and then use a saw with a small kerf to make my osteotomy. I do use a chevron, distally based chevron, just because I think it affords some inherent stability when you go back and reduce it. Some people will use osteotomes, or at least finish with an osteotome, because you're not losing as much bone when you then go to fix it and potentially compress across your olecranon. And then there's a variety of fixation options for the olecranon osteotomies. I tend to use a intramedullary screw, sometimes with a tension band. But there's plates, there's intramedullary devices that are designed for the osteotomies, and so there's a K-wire tension band construct. So there's a variety of ways.
And is there a certain distance from the tip of the osteotomy not the osteotomy, from the tip of the olecranon that you should do your osteotomy, or just kind of between those facets, like you were saying?
So I'll dissect, and you can see almost in that picture on the left, so that you can look into the joint and then look directly at the bare area. You don't want to make your osteotomy too proximal, because you run the risk of having a real small fragment with not a lot of fixation. And too distal, you run the risk of in your articular cartilage or into your coronoid. So it's something I will directly visualize, and then make my osteotomy right at the bare area. Some people will actually put a Ray-Tech in through the joint to protect it. I finish the osteotomy with an osteotome just because I think there's a little bit better better control. But I think it's important to do it right at the bare area, so you're not violating the articular cartilage.
Yeah, and then a little bit earlier, you were mentioning something about if you want to do a total elbow in doing an olecranon osteotomy. So is that something you should do, shouldn't do? Or kind of what are your thoughts on olecranon osteotomies if you're thinking of possibly doing a total elbow at some point?
So I think if the total elbow is a consideration, I think try to avoid an olecranon osteotomy. It's just another component you have to manage during your total elbow procedures. And so there's a variety of exposures for total elbows. You can do them with the triceps on. You can do a triceps tongue or a peel. But I think if you can avoid doing an olecranon osteotomy, in the event that you're planning a total elbow, I think that's best. That being said, I've particularly in some rheumatoid patients have managed distal humerus fractures with associated olecranon fractures with a total elbow and then fixation of the ulna. So you can do it. It's not like an absolute contraindication, but I think it's technically a little bit more challenging. And then you're also relying on that olecranon fracture to heal.
And do you ever, so we talked about kind of these posteriorly based approaches, are different, triceps on versus our triceps off versus kind of doing a olecranon osteotomy, which gives us the best visualization of the distal humerus. Do you ever do just a medial or just a straight lateral approach if you have like your partial articular distal humerus fractures?
Right. So if you have a partial articular, trochlear and or capitellar shear fracture, and that's an isolated injury, I will use a lateral approach. Isolated trochlear shears are fairly uncommon, and that I think would be an indication for a medial over the top approach. But most commonly for those partial articular capitellar shear type injuries, using a lateral approach. And that's whether you use a Coker or an EDC split. I think getting visualization proximally is important so that you can directly reduce that fragment. I think another component, and it's something I've heard David Ring talk about and publish on before, is that the majority of these capitellar shear fractures are not isolated capitellar injuries. They extend to some component into the trochlea. And that doesn't mean that you necessarily need to do a medial approach. But I think, going back to our imaging discussion, I think that's very important to know preoperatively how far that extent is into your trochlea, and if it's something that you can treat from a lateral approach.
Okay, cool. So say, we've done our approaches, we've gotten down, we can finally visualize our fractures. fragments, and it kind of comes time to fixation. What, I guess, just kind of slowly breaking it down. How do you decide what kind of plates that you're going to use for these, or are there some typical plate options for these distal humerus fractures, and then we can kind of go a little bit deeper from there.
Sure. So I think this is a controversy, within fixation of these injuries, and I think in general, there's two plating constructs that are used, and that's parallel plating, where you have a plate directly on the medial column, directly on the lateral column, versus perpendicular or orthogonal plating, where you have typically a direct medial plate, and then a posterior lateral plate. And so I think there's advantages, disadvantages to those, to both of those. I think the advantage of parallel plating, there may be some biomechanical advantages, particularly in varus and torsion. It allows for, as Jonah Driscoll talked about a lot, is that sort of recreation of the Roman arch and the interdigitation of those long screws from the medial and lateral side. Clinically, there's not been shown to be a big difference between the two constructs, but I think when possible, my preference is for parallel plating of these fractures.
And when it comes to plate, like actual plate choice, do you go with pretty like a 3.5 millimeter pre-contoured distal humerus plate, or do you go with a lock and compression plate like DCP plate? What kind of plate choice do you typically go for?
Sure. So a lot of I think regardless of the company, there's a variety of implant companies that make very good anatomic distal humerus plates, and typically on the medial side, I'll use a plate with the option for 3-5 screws proximally, and an anatomic plate on the medial side, and sometimes that'll extend down to the trochlea, sometimes just to the level of the medial epicondyle. And again, there's options for anatomic or pre-contoured locking plates for the lateral side as well, but there's also opportunities that you can bend a plate to fit where you need. So I think there's a variety of options, whether you're going to use a specific pre-contoured plate, or a 3-5 or a mini frag type plate that you bend.
And do you typically, I know you mentioned you kind of your 3-5 screws proximally in the shaft. In the distal humerus, are you using different? Are you using like 2-7 screws, or are you using smaller screws in the?
So, yeah, depending on the company, 2-3, 2-4, 2-7. And for the screws distal to the fracture, that's typically the screw size that I'm using for those.
And you typically for these the screws that are going into that distal fragment that are kind of getting that interdigitation of what you're saying, if we're doing parallel plating, are these all locking screws, or are some of them cortical? Are they all lockers or cortical, or is it a combination?
So typically proximal, I'll use cortical screws, and distal in the articular fragments, typically polyaxial locking screws.
Okay.
Either 2-4s or 2-7s. Sometimes, particularly in the case of with an articular split, you can put an independent screw across the articular surface, and I think particularly in cases where there's comminution, I think it's important to have the positional screw and not to compress across that, because you can narrow your trochlea. But in terms of the screws through the plate, I typically would use locking screws in that area.
Okay. And I guess as far as the length of the plate, how do you choose how far proximal you want the plate to go? Like I saw some things where they say when at least 3 holes proximal to the metaphyseal component, I mean, do you want 3? And then how do you, if you're doing parallel plating, do you want both plates to end at the same level, or do you want one plate higher than the other, or what? I mean, any thoughts on that?
So yeah, that's an interesting question, and I think there's some conflicting biomechanic information. In general, for each plate, I try to get 3 screws proximal to the fracture, and I try to end the plates at different levels to avoid a stress riser. So I try not to have the plates end at the same level proximally.
Okay. And then that's exactly that's the side here as well. I was going to ask you. Yeah, I already did. And as far as your sequence, so you go and, say you have a really highly comminuted fracture. Do you have a typical sequence that you do? I just put this here because this was something I read about. I read that some people. Yeah, go ahead.
I think this is a really important part, and I'll talk about this in the context of that there's a C-type fracture, and we're going to proceed with with parallel plating. I'll start by trying to reduce the articular surface, so turn a C-type into an A-type, and typically that's depending on how much comminution and how many pieces there are. It's with a variety of small K wires, 035, 045 K wires to get your articular block, your articular segment into one piece. I think an important side note. I think when you're putting in wires, screws from the medial side, I think very important, even if your nerve visualized, protected, to try to run that in on oscillate as much as you can to protect the ulnar nerve. Once you have your articular segment provisionally reduced with K wires, you try to bring that segment back to the shaft and hold that provisionally. The next step, I think you can apply your plates both on the medial and the lateral column. And I'll get provisional K-wire fixation both proximally and distally through the plates into the fragment. And so now you have everything reduced. You have both your plates in place, of where you want them. And I'll put a cortical screw in the oblong hole through both plates proximally, and tighten them down. Get locked screw fixation distally, through each plate. And then I think a really important part of really important step next is supracondylar compression. And so because you have that screw in the oblong hole, you can loosen it. You can take a large point of reduction or pararticular clamp and get sort of individual compression through each of the columns, and then tighten down your screws. And once you have that, you have a screw in proximally, a couple of screws in distally, as well as your K wires. Your fracture's reduced, everything's in good position. You have compression across the fracture, and then you can finish the rest of your fixation. And so those are the sort of general steps: provisional articular reduction, segmental compression or supracondylar compression, and then definitive fixation. Sometimes a little bit variable depending on how much your work your articular surface needs to restore, but those are the general steps that I follow for parallel plating.
And when you're putting your K wires in, where did you say that you're starting medial and putting them in laterally when you can, just because you know where the nerve is? Or
no, I think just depends on where they need to go. I think when you put wires in from the medial side, I try to run those in on oscillate just as sort of an extra layer of protection from the nerve. Often you have good visualization and a lot of bone in the lateral side, and so you can run K wires in from across there as well. But no, I mean, I think it depends on the case and depends on the fracture of where your provisional K wires have to go.
Okay, cool. And I think that was very helpful, Dr. Grandizio. I think that this has been great so far. And what I think we could do is, I know you have some cases that you have supplied us with. I think we can go through some of these, kind of tie all this together. Those that are listening, if you want to check out the YouTube channel, we'll post the cases there so you can actually see what we're talking about. But I will try to describe these x-rays as the best to my abilities that I can. But yeah, Dr. Grandizio, if we want to go through this, we can go through some of these cases and kind of I'll see how about this, we can try, and I can guess and say what I would have done, given my severely novice experience and not knowing much, and we'll kind of see if you agree, and then I guess we'll kind of go through what you did.
No problem, that'd be great.
Okay, let's see what we got here. So first one, 43-year-old female. It was a fall from a height, and we're looking at an AP and lateral radiograph from the elbow, which it looks like this shows kind of this shear fracture of this capitellum. Anything else that I see here? So I see this capitellum looks like it's kind of flipped up or displaced anteriorly or superiorly. Let's see. Don't see any. You can kind of see an outline of it here on the AP. I don't really see anything else. Maybe a little widening in the ulnohumeral joint laterally, but otherwise nothing else that I would have picked up on these films. Let's see, what is the next one? A CT? Let's see.
I know the next one might be what we
might be fixation.
Yeah,
okay.
Might be fixation.
So I mean, I think for this, I don't know if you need to do the whole like the medial and lateral plating. It looks like kind of you just need to get something to get this capitellar piece in. So what we were talking about a little bit earlier, maybe this one I may do like the lateral Coker approach, either try to go through, between anconius and EDC versus split EDC. And I would try to reduce that, and possibly, I think there are a couple ways. I think some people may do like headless compression screws through the capitellum. Yeah, I guess that's what I would. Yeah. That's probably what I would do. I don't know.
I think that sounds very reasonable. Let's see
what we did. So okay, so this is
I did have a CT. Sorry.
Oh, excellent. So we're looking at a CT scan that it's kind of just shows it's displaced. It's kind of comminuted. It seems to be a little comminuted superiorly, but completely displaced capitellar fracture. And okay, so you want to take us through kind of what you did here?
Sure. So I think if you look at the lateral radiograph, it's what's often referred to as a double bubble sign. So there's two lines or two bumps. And if you go back to the CAT scan, I had put that in there to show that this is very common with the capitellar shear fracture. We refer to this as a capitellar shear fracture, but this is actually a capitellar end trochlear shear fracture. And so you can see in the image on the right, that extends into the ulnohumeral region, the region of the trochlea. And so in the AP radiograph, you don't really get a good sense of that, but the lateral X-ray is enough there to let me know that this is extending into the trochlea. And I agree with you, that does not mean that you necessarily have to do, a medial approach, but I think you need to know how much of the trochlea is involved, and if you can address this injury from a lateral approach. And so in this particular case, I did a lateral approach and was able to fix it with headless compression screws. I try to get fixation in two planes. And so the shorter sort of anterior to posteriorly based headless compression screw, and then one that goes from lateral to medial, almost like a rebar type construct. I think there's some biomechanical advantages to that, of getting fixation in two planes. The other thing I'll say about these fractures is that in cases where you have some comminution of the posterior cortex, or an impaction, lesion, sometimes from the radial head. I think you can supplement this with a plate, with the idea of being able to get lateral to medial screw through your plate, and then A to P, headless compression screws. So I think a lot of different ways to go about fixing these in terms of construct and implants. But I think it's very important to recognize that a lot of these can extend into the trochlea and just aren't isolated capitellar shear fractures.
Okay. No, that's all excellent points. And so you're saying you may put a lateral plate and then put some screws to it just to make sure, I mean, put some screws through the plate just to kind of
correct,
reinforce
particularly
it.
in cases where the posterior cortex on the lateral side is not intact. I think it gives you some stability, some added stability to get fixation from lateral to medial.
And are these 2.7? What size screws are these? Are these 2.7 screws here?
Those are 2.7 cannulated headless compression screws. There's a variety of different screw types and sizes available, but those are 2.7 headless compression screws.
So you reduced it, had a K-wire, and then kind of drilled over the K-wire and put these screws in?
Correct. I try to get a initial K-wire outside of where I think my fixation will be, and then you can use the wires from the headless compression screw to hold your reduction provisionally, and then drill over. I think the other thing that's important in these is really to understand your lateral X-ray. We often talk about having the three circles if you get a perfect lateral of the distal humerus, and so those three overlapping circles are the central spool of the trochlea, the capitellum, and then the medial border of the trochlea. And so your widest circle, the widest diameter, is your medial border of the trochlea. Your capitellum is in the middle, and then the really narrow one is your central spool of the trochlea. So I think it's helpful, particularly when you're assessing your reduction and assessing your implant position, to kind of be able to critically assess what's what on a lateral X-ray.
Yeah. So when we're looking at this one, injury film, so it looks like we have this fragment here. I thought this was just that, but it was rotated. Mm-hmm. And then is there anything, I mean, maybe this little piece of comminution here, but is there anything else on here that you see that you would have picked up on that we may not be picking up on, or that I may not have picked up on?
No, I think you covered it. I mean, I think that double bubble sign, can clue you into there's a capitellar shear and potentially with extension into the, potential extension into the trochlea. And I know we had talked about this earlier, but this is a fracture that I routinely get a CAT scan on.
Yeah, cool. All right. Well, let's see here. What do we have here? So we have next case. This is a 77-year-old female who was in a motor vehicle collision. Again, we're showing AP and laterals of the elbow, which shows this kind of this medial sided shear fracture, and it seems to involve intra-articular. So intra-articular looks like a type B, involving right into the kind of trochlea. So intra-articular piece right through the trochlea. This is displaced on our lateral. This seems to be, I think that's missing capitellum. So it looks like our capitellum is often displaced. And then that's what we have on the medial side here. Let's see, is there a CT scan?
Yeah, there's a CT on this one.
All right, let's see. Oh man, yeah, bad injury. So CT scan just showing that it is a little bit more articular damage than I would have initially thought, as well as this kind of posterior fragment. So for this,
it's like an old in training question with two oblique X-rays.
Yeah, I know. So for this, what I may do is I would probably do an olecranon osteotomy. I think I'd go posteriorly, do an olecranon osteotomy. See what you can do. See what you can see. Reduce the capitellum, reduce the medial side. So I may do orthogonal plating on this. I think you can do both. I think you can either go orthogonal or parallel plating, but I would possibly think orthogonal, because that posterior lateral plate, you can get some screws into that capitulum, and on the medial plate, you can kind of buttress that medial fragment. But here, let's see what we have here. Oh, no. Completely off.
I think that if this patient was 24, you make every effort possible to fix it. And I think there's a couple of things from the x-rays in this case is that, in the lateral, you get a sense that there's a shear injury to the capitulum and trochlea. And then I think much better appreciated on the CAT scan is the fact that this is a very low transverse fracture.
Yeah.
And so the combination of those two things in older patients, and I believe this patient's in her mid-70s, are an indication for a total elbow arthroplasty. And that's a whole separate discussion. There's some classic articles and showing for common intra-articular fractures in patients over 65 that the results of total elbow may be better than ORAF. I think that even in this age group, if the fracture is able to be fixed, a C1, a simple intra-articular fracture, I would lean towards fixation over arthroplasty.
Okay.
We run into a low transverse fracture, with shearing injuries. At least in my hands, that's not something that I think that I could get anatomically reduced and stable to allow for early motion. And so those are the fractures that in the patients in their 70s and their 80s that I lean more towards, total elbow arthroplasty. I think that that's, not a discussion or decision that's taken lightly. There are certainly complications with total elbow for fracture, and it's but I think that in that population and for this fracture, I think a better option than fixation.
Okay, so key things here: older elderly patient. This very low transverse fracture with the kind of shear components, be pretty hard to get enough screw fixation distally into that fragment, and especially given her age, why total elbow was chosen in this patient.
Correct.
Cool, good case. Let's see. All right, here we go. 42-year-old female is in a motor vehicle collision. It almost reminds me of those pediatric type fractures. But let's see. So we have an AP in the lateral of an elbow, skeleton mature individual. It seems to show the articular surface seems to be okay, but definitely get a CT on this. But it kind of shows this to the naked eye, to me, what seems to be like this partial articular fracture of the distal humerus, comminuted. Let's see, on the lateral, I mean, it's displaced anteriorly. Definitely to have a good neurovascular exam for this patient, but the joint itself doesn't look too bad.
No.
To me. Let's see. Do we have a CT on this? Let's see.
I don't.
Oh, boom. All right. Let me try to. So for this, I probably would have done I'd probably go posteriorly. I think you could work through paratricipital windows for this. I don't think you need to do an electron osteotomy. And I would definitely put a plate laterally. I'd probably do parallel plating with this. And yeah, I think that's what I'll do. Let's see what we have here. Almost right. Orthogonal plating. You want to take us through this?
This is interesting. This was a case actually of my early on this was in my board collection period. So she had a non-displaced intra-articular split, and that's a positional screw across the fracture site. And again, my preference is for parallel plating. And in this fracture, I thought I would be able to get more fixation using a posterior lateral plate. And this is actually her x-rays at 6 months. She had a non-union.
Okay.
I think there's a lot to discuss for this. So this was an atrophic, an atrophic non-union. And if you look, I ended the plate at different levels. And I think what I failed to do here was get adequate supracondylar compression. And so if you look at this, it's an extremely rigid construct. So there's multiple locking screws just distal to the fracture. Proximally on that posterior lateral plate, there's a lock screw just proximal to the fracture. And so this was at least in the metaphyseal component, a simple oblique fracture that was fixed with a gap without adequate compression. And in addition to that, it created an extremely low strain environment because there's rigid lock fixation kind of all over. And so that combination, gap, lack of compression, low strain environment, is a recipe for non-union.
Yeah.
And fortunately, she healed somewhere between 9 and 12 months from what I remember, without any further any further intervention. So at this point, a delayed union. But I think it's often very easy to go back and say, oh, this was high energy and she's a smoker and this and that. But I think that early on, this was a technical failure of mine, and a case I learned quite a bit from.
And so if you're doing this again, if you had to go back and redo this, you would still keep the medial plate, but you do parallel plating for this. And then one of the things that you would say that you try to get that supracondylar compression. So you'd use a periarticular clamp to and you put it on the sides of both of these plates, and then you you loosen that screw and put another 3/5 screw in. Is that correct?
So yeah, and again, I don't think there are any issues related to the posterior lateral plate. I think a lot of people use that, and there's certainly a fine construct. I think if I was doing this again, I would have chosen parallel plating. I would have put a provisional cortical screw in the oblong hole in the shaft, and then got compression, through the fracture. Better than I did before getting the rest of my fixation proximally and distally. And so I think in this case, it's important to get the supracollar compression before you get your definitive fixation. And you can do that with one screw in proximally in the oblique hole, and you can just take a clamp and compress with the clamp.
Cool. And looks like probably we got one more case here. Last one here is 24-year-old female, and we're looking at an AP, and we have a coronal. I'm not a coronal. We have an axial cut of the distal humerus. It shows intra-articular fracture. It's very displaced. It's comminuted medially. So, for this is one I may do an olecranon osteotomy for this, just to. It's somewhat simple. I don't know. I may start with the paratricipital and see what we can get. And then definitely a plate medially, given that comminution. That's kind of where we kind of need to put a buttress there. And then laterally, I guess you could either go with a posterior lateral or just you could go with orthogonal or parallel on this, but let's see what we got here. Okay. You want to take us through what you did here?
Sure. So I think this is a good example of exactly what you just said, that you can do the paratricipital and you can see if you can get it reduced and fixed. And if you can't, you can just extend and do electron osteotomy. It's not that much extra work. You never really regret doing it. But I think in this case, even with an simple intra-articular split, I didn't need it to get it reduced or fixed, so I was able to leave the triceps on. And so this is sort of a more classic example of the steps. So you start by reducing the articular segment, and that's a positional screw. Taking care not to compress because that'll narrow your trochlea. Positional screw. Get your medial and lateral plates on. Your single cortical screw in the oblong hole proximally, a couple of lock screws distally through each plate, and then you can get really good supracondylar compression, through each of the plate, and then finish with your, definitive fixation. And so this is, I think, a more classic example of parallel plating construct and the steps you would take to do this.
Awesome. And then one more here, 55-year-old male. And let's see, I gotta take what I'm looking at. So we have AP in the lateral. This seems to show, gotta get my orientation here right.
Yeah.
So on the AP, or somewhat of an oblique, it looks like it's kind of more the supracondylar fracture. I can't tell if it's impacted in.
I think very similar to the other one in that you can kind of get a sense of a non-displaced intra-articular split.
Yeah. And then you want to quickly take us through what your thoughts were on this?
I think very similar.
Very similar.
Again, I think even in these, you can start with the paratricipital approach. And then, if you need to extend, which in this case, I was able to get the articular surface reduced, without an osteotomy.
Great. Looks good. Well, Dr. Grandizio, I would definitely appreciate you for coming on this podcast. We learned a lot about distal humeruses, I think we definitely talked about a lot about, we talked about the different approaches. We talked about different fixation constructs. We talked about anatomy. We even briefly touched on history and physical exam findings. Is there anything else that you want the people to know about, kind of before we wrap up here? Any last words for these distal humerus fractures?
No, I think we covered a lot. I really enjoyed it. I think that preoperative planning in these is really important, and something that I continue to do for all of these cases. You should go in with a plan A, but be prepared for your your plan B and plan C. And I think a big component of the preoperative planning is to make sure you have appropriate imaging and understand your fracture before you get into the operating room. I think that when you have an understanding of your fracture geometry and your pattern and what you're going to do, it makes a decision making of what approach, what am I going to do with my nerve, what plates. I think the more of that you can decide before you make incision, the less stressful some of these cases can be, because particularly in younger patients and comminuted fractures, they can be somewhat stressful.
Yes, I completely agree. And Dr. Grandizio, we always, for our guests, we always state, if you have any social media or anything that you want to shout out for people to follow you on or contact you or anything, if you want, feel free to share it. If not, that's completely fine too. But totally up to you.
I don't have any social media. I have my email on there. If there's any questions, chris.grandizio@gmail.com. But I really appreciate it. This was a great time, and I appreciate you having me on.
Of course, we appreciate you taking the time out to come on. For those that are listening, thanks again for listening to another episode of the Nailed It Ortho podcast. Don't forget to hit that subscribe button, and please go and leave a review in iTunes and let us know how much you enjoyed this episode on distal humerus fractures. And until next time.